My name is Joost Daemen. I'm an interventional cardiologist in the Erasmus University Medical Center in Rotterdam, the Netherlands. And today it's my pleasure to co-host this session together with Professor Christoph Hammerstingl. We will focus on the updated ESC guidelines on patients presenting with chronic coronary syndrome. We will discuss a little bit on how these guidelines may interfere within our routine clinical practice as of today. We will look a little bit into the details of the guidelines with respect to the position of IVUS in our cath labs, show you some examples on what complex PCI actually entails and how IVUS may actually change your practice in these particular cases. We'll discuss on how the impact of potentially having a higher volume of IVUS cases on a daily basis may interfere with your daily workflow within the cath lab, and provide you with some tips and tricks to make that as smooth as possible. And finally, we'll discuss a little bit on how to integrate the full team, the technical staff, and the technical setup within your lab to get the most out of the most recent guidelines, and finally to allow best patient care under 2024. So with that, I would like to pass the word to Christoph to start the discussion.
Thank you very much, Joost, and it's my pleasure to be part of this, I hope, fruitful and educative session about intravascular imaging. And I was really glad to see the new guidelines, and I hope that we can give you some important information and practical tips how to apply these guidelines in your daily routine, and what was the reason to give this strong recommendation. And maybe we just start with a deep dive into the new guidelines. And Joost, maybe you just can give us a brief overview of the updated guidelines. What do you think is the most important aspect of the new guidelines, and what might be the impact of the guidelines in daily clinical routine?
Yeah, that's a good question, Christoph. So what is interesting is that we've been using IVUS actually for the last 30 years already. And despite the fact that there are now 18 randomized controlled trials showing you actually virtually unanimous positive effect of the use of IVUS guidance versus angio guidance in routine practice, that still, as of today, the guidelines, or at least the recommendations to use IVUS in daily PCI were not that strong. Maybe it's good to first quickly reflect on the most recent coronary revascularization guidelines that were published in 2018 already, in which the use of IVUS actually was restricted to a Class 2A recommendation level of evidence B, to be used in patients with unprotected left main coronary artery disease. And I think that is something that has been present for the past decade. If you ask people throughout the world where do you use IVUS, probably the first thing that they will mention is patients with left main disease. And that is exactly per the guidelines that are now in place since over 6 years. Secondly, there was a consideration for patients presenting with instant restenosis, in which there was also an indication for either IVUS or OCT, with a class of recommendation 2A level of evidence C. So also an indication that got some, let's say, recommendation in terms of the potential benefit to use imaging in this particular patient subset. And then finally, for procedural optimization, so there was actually a separation between screening and guidance and post-PCI optimization. The guidelines specifically gave a level of evidence, a 2A recommendation level of evidence B, to use either IVUS or OCT to optimize standard ablation, or to guide treatment of left main disease. So 2A recommendations suggesting that the use of IVUS may be considered. Now, in the most recent guidelines, and this is actually for the first time in history, and this is just a overview of the 2024 guidelines on chronic coronary syndrome, as published by our colleague Christian Vrins from Belgium. Now, finally, making a very strong and clear statement on the fact that intracoronary guidance by either IVUS or OCT is currently now recommended in performing PCI on anatomically complex lesions, in particular left main, through bifurcations and long lesions. But as an aggregate patient with complex lesions, with a 1A recommendation in the current guidelines.
What do you think led the decision to upgrade these guidelines? You give this very strong recommendations. Do you have some ideas of this?
So what led to the change in the guidelines is actually the fact that by now we have 17, and as of today, perhaps even 18 randomized controlled trials comparing either imaging-guided PCI as compared to angio-guided PCI. And a wealth of indications, including patients with CTOs, long lesions, instant restenosis, complex PCI in general. And without dwelling in all the individual details of the trial, what perhaps is the most critical change within the guidelines is the fact that, as with the ESC meeting last September, the evidence that was available and mostly generated in Asian populations was now finally, for the first time, also let's say extended to more Western populations with the publication of the IVUS trial, Renovate Complex PCI, and most recently Lumion 4 and the October trial. And this is just a slide showing you an aggregate of the pooled analysis, so to speak, of patients presenting with PCI, pooled together in a meta-analysis published by Greg Stone and Lancet earlier this year, showing for the first time ever a relative risk reduction of 0.75 for all-cause death. And that's actually quite interesting because there are not so many things we do in medicine that actually lead to a 25% reduction in all-cause mortality. But this is something that is, I think, very strong and precludes the need to dive into all the nitty-gritty details why this may be the case and whether the evidence is strong enough or not. In the past, we had significant reductions in cardiovascular mortality, but now even if you dilute that and include non-cardiovascular causes as well, you still have a 25% reduction in all-cause death. And that, I think, is extremely strong. If you look into more detailed lesion-specific characteristics and the impact of imaging on those, we find again a 31% reduction in target lesion failure across the spectrum of these 18 randomized controlled trials, including over 11,000 patients. So those, I think, are very strong findings that made the guideline committee believe that now finally it was time to upgrade the guideline from a 2A to 1A recommendation for the use of imaging.